time I've been introduced as Momo, so thank you. My grandson just turned a year in August, and he finally said my name. He says Mama, so I was like, Momo, like leave that alone. And he finally said it, so he has me wrapped around his little finger. So happy to be here with you guys. I know Melinda did a great job kind of setting the stage, and I feel like we've lived parallel lives, Melinda and I. So some of the things are going to be similar, some might be just a smidgen different, but we're going to dive into kind of the ins and outs. We're going to go from basics to the research to back it up. I always try to make sure that I'm providing as much, clinical background as possible, because patients have questions, other your colleagues might have questions, and for you to be able to pull that research, I think, is valuable. Melinda did a great job explaining the difference between bioidentical and synthetic. We're going to kind of dive into that. We're going to look at some of those different testing modalities, look at the safety, and then review some of the benefits, like why do we want HRT? And then I have a couple of case studies that we can go through as well. So like Melinda mentioned, bioidentical is exact structures what our body produces, and synthetic is different. It might do some of the same functions, but then we're going to have some different side effects as well. It's like the whole lock and key. The key might fit into the lock, but it's going to turn it a different way. So trust me, there's not going to be testing on the on these structures, but just looking at the difference between basically Premarin or conjugated equine estrogen and estradiol. So that basically conjugated equine estrogen is mainly that estrone, and you can see that those side chains are very, very different than what we see with the estradiol. Same thing, progesterone and medroxyprogesterone acetate. Those side chains are very, very different. And a lot of times I've had prescribers who are like, oh, well, they're the same, right? I'm like, well, would you give MPA to a pregnant woman? They're like, oh, absolutely not. Well, then they're not the same thing. They are going to do very, very different things. The difference between testosterone and methyl testosterone, just that small little methyl group on the side, makes all the difference. Testosterone is not absorbed well orally, and so that's why the manufacturers came on and said, well, we can increase the oral bioavailability if we methylate it. Still not a fan of that, but that small little molecular change makes a difference on absorption. Testosterone versus testosterone cypionate. So that ester side chain, that's what makes it long acting. Really, that only really works with the injectable portion of that. I've had, pharmacists say, well, the doctor wanted to do testosterone cypionate topically. Don't think we're going to still get that same breakdown of that ester side chain when we're doing it topically versus the injection. So just trying to understand the difference between that. All that really separates testosterone from estradiol is that one hydroxyl group. And sometimes our patients are like, I don't understand why this makes a difference, but they do understand that testosterone is very different than estrogen. They know that testosterone is the man hormone and estrogen is the female hormone, even though we all have a little bit of everything. But if they can see that, oh wow, that's the only thing that makes those different, you can see that these small changes can make a big difference in how it impacts our body. And that's also how they interconvert back and forth too from testosterone and estradiol. Okay, so this is a PDF version, so it gives away my little joke here. But I was so excited that one of my colleagues had come up with this joke, and I was sharing it with my kids. Well, the middle school science teacher ruined it. The kids were like, yes, Mom, we know this joke. So just showing that, water versus hydrogen peroxide, very, very different. And it's just that one little molecule that makes a difference. So just to reiterate, the synthetic is not the same thing as bioidentical. And really, progestin versus progesterone, I encourage you when you're looking at research, really dive deep. Really make sure you understand what they were using, because those terms get used interchangeably all the time. And it's like nails on a chalkboard for me. It really, really drives me crazy. So to me, that's the biggest one. Progestin is not progesterone. But how are we going to look at our patients? I think Melinda did a great job setting the stage, talking about the bathtub. Like, we need to look at all of these aspects of our patients. There are some providers that are like, oh, your labs are fine, move on. And others are all about the symptoms and, oh, labs don't matter. And actually, if you look at package inserts of some of these commercial hormones, they say don't test. Well, when we get into the testing, I'll explain why they say don't test. But it really is all of this and what's going on, how the patient's set up, are their genetics, their lifestyle. What are all the factors that go into how we determine what we do with our patients? All of those are pieces of the puzzle. So pharmacists call me in my clinical role. They call me whenever, like, you go into your talk to your pharmacist. And you're like, hey, I have this crazy patient, and Chris might say, hey, Sarah, this doctor just called this crazy patient. Help me out, right? And so we're there to help support. So I hear all sorts of things. I like to think that I'm the 3-year-old that always wants to know the why. And so I found this quote. I loved it. I was like, half the science is asking the right questions. I ask a lot of questions because I want to try to, again, put all those pieces to the puzzle together. And it's not straightforward. It's not clear cut. I wish it was more black and white. I love black and white, but most of it is not. It's very, very gray. So we have to ask all of the right questions. So PCCA has a confidential hormone evaluation. Basically, I don't know how to explain what PCCA is. We're Professional Compounding Centers of America. We support compounding pharmacies like Rx3 all over US and Canada. But we came up with this hormone evaluation form just to help kind of set the stage, help try to ask all of those questions, their symptoms, their lifestyle, their genetics. I think Melinda mentioned about how toxic they are. So that's why I want to know their occupation. Are they a hairdresser and they're around a lot of dyes and chemicals? Or is their hobbies? Are they a welder on the side? What kind of toxins are they exposed to? As well as getting into some of the nitty gritties about other things that they're consuming. And then bowel movements. It's so funny because I'm on the phone all the time. My kids have basically grown up over the last 12 years listening to me answer all these questions. It's so funny. It's funny when they try to mimic me. It's a compliment, right? Anyway, but I always ask about bowel movements, and the kids are like, "Mom, why are you talking about poop again?" Poop is so important. It's package in, package out. And so one is a bare minimum. I like 2 to 3 bowel movements per day, like especially if we're having decent sized meals, we need to make sure we're moving things out. So super, super important. Hours of sleep, quality sleep as well as quantity of sleep is so important. And like I said, all of these things play a vital role in how we evaluate our patients. Then also there's the testing. There's a variety of testing. I did the A4M fellowship, and I would sit in one lecture and they're like, oh, serum, that's the only way to do it. The next lecture, oh, saliva is the only way to do it. The next one is, oh, urine. My head would be swimming. I like to think that we are very fortunate that we have these different buckets. We have these different modalities, and I feel like they all tell us something different. So when they say you're not going to get the results that you're looking for, they're just mainly talking about serum. Sometimes it's hard to catch that topical dose in the serum, and so they say, oh, well, it's not reliable, you can't use it. So anyway, I'd like to look at all 3 areas. And timing really, really matters. And this, regardless of the type of testing that you're doing, when did they use their last dose versus when you're testing? I had this one provider that they would send me their labs, and I'd be looking over the labs. I'm like, oh my gosh, I guess we need to increase her dose. Like, she has nothing. And then I talk to the patient. Oh yeah, I haven't used it, for the last 3 months. And I'm like, well, why did we test? But and then sometimes it's like, are we catching a peak? We testing a trough. Me personally, I started on a sublingual testosterone. I wanted to see what my peak was. Didn't tell my provider, and so I took it that morning. And then I had my labs drawn, and when the labs come back, I'm like, don't freak out. That was a peak. Next time we'll test a trough. And she's like, she tolerates me. But anyway, she knows that I kind of know what I'm talking about. But knowing that information is very, very helpful when we go to evaluate those results. And like I said, it doesn't matter what form of testing we're doing, we need to know. And also take into account, that's a one-time snapshot. That's a picture of what happened right at that moment. And there's so many other things that come into play that I'm not one to just automatically make a judgment from one test. But what test do I really like to see? It's funny, I just had my labs done, and so I'd had my list of things I wanted to ask for, and then my sister-in-law was like, hey, I'm going to the doctor. I was like, copy paste. She's like, wow, that was fast. I'm like, yeah, I already had mine laid out. And it was very interesting when a sister-in-law said that the doctor was like, we don't normally test progesterone. And I'm like, but you're on progesterone. So why? She was like, I thought that too. So yeah, we need to make sure that we're testing all of these. I like to look at the free and total testosterone, sex hormone binding globulin. Melinda alluded to that. So helpful to kind of know what's going on. Homocysteine, I know she had that in a few of her slides, and I like to say it's a poor man's way to know whether they were methylating or not. So you can do the genetic testing to see if you're a good methylator, but homocysteine is a good measure of that. So if they're already taking a lot of B vitamins and their homocysteine still high, chances are they're not a great methylator, and they're going to need methyl B12, methylfolate, P5P, the pyridoxal 5-phosphate. They're going to need things already ready to be used. And a lot of times you can see that homocysteine level come down. Ferritin is super important for converting T4 to T3, and especially if you have a woman that's have heavy menstruation. Let's see what's going on with her iron as well. And vitamin D, it is just it's really is a hormone. It really isn't just a vitamin. And I live in Texas, and even though we get lots of sunshine, people are still low in vitamin D. So we need to make sure we know where that is. That full thyroid panel, I always tell patients, I'm like, go into your provider and they just check a box for thyroid. You're not getting all of these things. Those codes have to be written in just to see, are we converting T4 to T3, or are we converting it to reverse T3? Where T3 is the gas, reverse T3 is the brake. And so you can have someone that is not, they're very symptomatic. Their TSH can be perfect, their T4 can be perfect, and they still feel lousy. So we really need to get down to some of the nitty-gritty results of that to see what's going on. Fasting insulin and fasting glucose. All of you always run fasting glucose, but many times fasting insulin gets overlooked, and our body does everything it can to hold on to that glucose control until it can't. But we can start to see that picture a little bit earlier if we're looking at the fasting insulin as well. Hemoglobin A1C, obviously a good thyroid or cholesterol panel, and then that 4-point cortisol. And that really is the gold standard for cortisol testing is saliva. And that is, just simplicity, right? You're not going to go into the lab 4 times in one day to get labs drawn. And then some people are scared of needle sticks and then traffic, and that can definitely affect your cortisol levels. I don't like to look at a cortisol in serum unless there's something like seriously going on. But if we really want to see what's going on with their cortisol, I like that 4-point saliva. And not to leave our gentlemen out, we definitely want to look at their free and total testosterone. We also want to look at their estradiol. Are they converting their testosterone to estradiol? Because if that's the case and we give them more testosterone, they're just going to make more estradiol. So we need to know what's going on there. I like a good baseline PSA, really making sure what's going on with our hemoglobin hematocrit. If that's already high, let's fix that before we add testosterone to the mix. Definitely have known gentlemen that have had stroke from too much testosterone because their H&H was already super high. And the same thing, some of the similar labs as well. Thyroid, hypothyroidism, and low vitamin D have also been linked to low testosterone. So let's not overlook some of those things for our gentlemen to make sure that it's not just replace their testosterone. Again, the 3-year-old in me wants to know the why and ask the questions. So make sure we're evaluating that thoroughly as well. And so, I'd have patients say, well, gosh, my doctor said everything was normal. My labs came back, everything is normal. Well, it's also normal, that normalization is per that lab, and it's their average patients that they have, if that's what's considered their normal range. I like to look at what's optimal, what's ideal. Like Melinda said, we don't wait till someone has a hemoglobin A1C of 6 before we say, oh, gosh, you're diabetic. Things were happening along the way that if we had been checking things, we could have made some course corrections, and really trying to strive for optimal is what we want to look for. And sometimes in those labs, it says, I've had patients say, oh, well, the doctor says my estrogen is normal. I'm in the postmenopausal range. And I'm like, yeah, well, that's women that have no hormones. And I don't know about you, but that's not where I want to be. I don't want to be in the range of women with no hormones. I don't know that I want to be the 35-year-old. I just turned double nickels this year, a couple of weeks ago. And I don't know I want to be a 35-year-old, but, I feel pretty good for a 50-year-old. So, we want to have a good range for those patients, but just kind of keeping in mind, those levels are dropping, but we don't want to be, in that normal range for menopause. I thought these were some interesting articles just looking at seasonality of our labs. And this is definitely true for vitamin D as well. I like vitamin D tested at least twice a year. So end of summer, when maybe they've gotten a little more sun exposure, in the beginning of spring where they've had all winter of not as much. And really maybe that tells us that we need to bump their vitamin D maybe over the winter months a little bit more. But I thought it was interesting that we also saw these changes in the hormone levels based on the seasonality. So again, kind of important to know. So Melinda alluded to this as well. If hormones are so great, why are more women not using them? And the WHI is why. And I didn't realize what a gift it kept giving. Like people already being taught, the hormones, and it's just we're definitely fuels fuel in my fire that we want to continue to help women. I remember this date very specifically. I was in a doctor's office for doing a lunch, explaining why he needed to do bioidentical hormones, and he told me I was crazy, and he was going to be taking all of his patients off of hormones because this study had just hit the newsstand. And I, I'm a little maybe sassy, and I said, well, then are those patients going to come and live with you because their family might not want them? Very side note of that, about 3 years later, he called me about his wife. I don't have a poker face. Thank goodness it was over the phone, and I was able to be very professional and help his wife. And inside, I was like, oh, I told you so. But this was just terrible of what this did for women. And so, like I mentioned earlier, we always want to look at exactly what they used. What was the drug? Was it synthetic? What was the dose? What was the route? All of those things, I think, is what makes research on hormones so confusing because it's all over the board. So with the WHI, we did see a decreased risk of hip fracture, decreased risk of colorectal cancer. But really, I think the bad boy in this study was the medroxyprogesterone acetate. Seeing the increase in pulmonary embolism, stroke, breast cancer, to me, that's all the synthetic progestin. What's interesting is prior to the 2002, there was a study done on rhesus monkeys, and basically rhesus monkeys internalize stress very similar to how we do. And so they gave one group progesterone and one group medroxyprogesterone acetate. They saw vasodilation in the progesterone group, and they saw vasoconstriction in the medroxyprogesterone group. So when this came out and they were like, oh, there were increased strokes, and I was like, did no one see the rhesus monkey study? Like, why is this a surprise to everyone? So, not that I don't like oral estrogen at all, but there were some positive things that happened on the estrogen-only side, like the decreased risk of breast cancer. That did not get publicized anywhere. The hip fracture, and we think, oh, a hip fracture is bad. No, a hip fracture can be a death sentence, especially for an older patient. They just don't come back from that. And so they didn't see on the equine estrogen side, didn't see any effect on the coronary health, heart health, or colorectal cancer. The increased risk of stroke and pulmonary embolism, I think, was because it was oral. And like Linda said, that hepatic, process of going through the liver increases those clotting factors, inflammatory factors. We'll talk a lot about inflammation later when I'm talking about LDN. So again, just looking closer at it, they were trying to determine, does HRT reduce cardiovascular risk? Why did they choose the population that they did? I have no idea. That had been postmenopausal for many years. Their receptors were downregulated. Like, it didn't make any sense how they chose their patients. But just looking at the group with the medroxyprogesterone acetate, all those things were elevated versus what we saw with the equine estrogen only. And this to me should have been the headline of the articles, but nobody asked me. It remains possible that transdermal estradiol with progesterone, which more closely mimics the normal physiology and metabolism of endogenous sex hormones, may provide a different risk-benefit profile. Why wasn't that across the newsstands? But anyway, so it's like I said, it's the gift that keeps giving. I realized a few years ago how they just stopped teaching it. And so I'm glad that I applaud you guys for being here. I applaud y'all for learning more and continuing to help women out there with all of their options. Because the limitations of this study, the one dose, the one route, synthetic, the age of the patients was just not great. And with that sharp decline, it scared people. I mean, I even had patients that were on bioidentical that were like, they were scared. And then I had a 70-year-old woman who came back in probably about a month later, and she was like, I don't care what that study says. Can you call my doctor? Like, I can't think, I don't have energy, and I feel like I'm drying up like a raisin. And so I was like, absolutely. And I never wanted a patient, if they were afraid of hormones, there's a big mind-body connection. Like if you're afraid of it, I don't want you to take it. Let's work through this so that you are okay with taking this, because there's some sort of signals that happens when you try to go against what your body is thinking. So, but this decline was awful, and this study right here just absolutely breaks my heart with how we saw the increase in hip fractures after this. So women got scared, they stopped taking it, and now many of them were dying. There was an excess deaths in women that had hysterectomies between 50 and 59. And it says, our analysis suggests that failure to differentiate among populations of women in preparations of hormone therapy has cost thousands of lives. That just absolutely breaks my heart. And that's not to say like the ones that were told they were crazy on antidepressants and all these different things, when hormones play such a huge role. So there was an 18-year follow-up. I don't know if you guys are aware of that. There was an 18-year follow-up that obviously did not hit the newsstands. And even the ones that did the combination therapy, they did not see a risk of all-cause cardiovascular or cancer mortality during the 18-year follow-up. So hormones played a huge role in helping these ladies, even though they weren't using the right dosage, weren't using the right hormones, there was still a benefit to these patients years later. And just they were kind of comparing the two different therapies with placebo. Obviously, estrogen only was more favorable for Alzheimer's dementia. You can see how placebo was better for breast cancer risk, and it was with the combo one, and it really was the medroxyprogesterone acetate. And we'll talk about how that can increase the proliferation of the breast tissue, where the estrogen only was more favorable. Because the progestin will reverse the protections that estradiol has, the cardiovascular protections, and the progestin antagonizes those effects. And like I said, it's more vasoconstrictive, where natural progesterone is vasodilatory. This was a study looking at progesterone gel and how it enhanced the effects of estrogen on exercise-induced myocardial ischemia. And that the choice of what you use really makes a difference for your cardiovascular patients, or just in general, just patients in general. It's really important. So this was a study looking at breast cells and which type of progestin were used, and medroxyprogesterone acetate was the most proliferative, where progesterone had no significant effects of proliferation. So again, if patients are concerned, and I've had people say, oh, my doctor said I can't use progesterone because it causes breast cancer. And it just really makes me scream on the inside. And I find the data and send it to them like, no, you're confusing that with a progestin. So this is a good study looking at that. And testosterone, basically we think of testosterone for sexual function, but it has many, many other effects. But sometimes our, premenopausal women have, need some testosterone as well, just depending on what's going on. If they're on oral contraceptives, it's very common for them to be low in testosterone. So sometimes we can give a little boost there. I don't like to give testosterone unless we show labs are low. And especially in our postmenopausal women, about a third of women make plenty of testosterone postmenopausally from their adrenal glands. So just because they come in and they say, oh, my libido's in the tanker, it's not an automatic that they need testosterone. We need to test because estrogen really is a big player in that as well. So is thyroid function as well. But testosterone can improve mood, well-being. I've had ladies say, oh my gosh, I started doing my hobbies again. I have more confidence. I just felt more like myself. And so it's just important to invite everyone to the party. So make sure that estrogen, progesterone, testosterone, everything is properly balanced. But as far as breast cancer risk, they really haven't seen any increased risk with testosterone. We're starting to gather more data with the patients transitioning from female to male. They're on much higher testosterone. We're not seeing increased cancer risk. Your PCOS patients that have higher testosterone, we don't see an increased risk of breast cancer. And actually in the animal models, they're showing that androgens can inhibit breast cancer growth. Dr. Rebecca Glacier, she was a breast cancer surgeon. Her speak years ago, she's since passed, but she said that all of her breast cancer patients that came in had high cortisol, high and low testosterone. That was like the common theme between all of her patients. So I think testosterone has an effect on our immune system as well. And so, we're all walking around with cancer cells. It's just what does our immune system do with that? So testosterone can be a vital role in that. So what about the increased risk of venous thrombosis? Oral estrogen definitely is the big culprit. It can have more of that through prothrombotic effect. So administration is key. Oral but not transdermal estrogen is associated with increased risk of VTE. The transdermal route avoids that hepatic first pass effect, and so you don't see the increased risk of DVT. Oral estrogen is associated with a marked and rapid increase in C-reactive protein. And I know Melinda was very, very kind when she said, you can do what you want. And I'm not saying you have to. I'm saying you can't do oral estrogen. Please don't do oral estrogen. And I know there's plenty of products out there, and I know some of those patients do fabulous with it, but there's just so much data that it just doesn't make any sense to me why we are still doing oral estrogen. If you have young women that are needing contraception, I mean, obviously, I'm a mom of 2 girls, and abstinence is the best thing, but there's also reality. So, we can do a copper IUD. There are some transdermal hormones, that we can, or, contraceptives that we can do. Please don't do it orally. Their increased risk of breast cancer, it just is crazy high, plus the inflammation. So please, please, please don't do that. Okay, so NAMS concluded that the risk of hormone therapy differs depending on the type, dose, duration, route of administration, timing of initiation, and whether a progestogen is used. Progestogen is kind of all-encompassing. It's the synthetic progestin and progesterone is included in that. Another confusing term that gets confused. The one part of this that I really, really dispute is the duration of use. There used to be this thought that, 5 years to protect your bones, that's all that you need. And we'll talk about bones in a minute and how that's dispelled. Someone is going to have to pry my hormones out of my cold dead hand. Like I am not stopping my hormones. Like I want to be that very active grandmother and, keep my brain because I love what I do and I love educating. And the duration I think is for lifetime. Melinda reminded me that someone at our last conference said that, when do you stop hormones? And they said, well, 10 years before you want to die. Anyway, don't plan to stop it. This was some research that was pulled. There's a ton of things. I really feel like the tide is shifting. I mean, you guys are seeking out more information. I talked to pharmacists all over the U.S. that they're like, our doctors need help. We need to educate these doctors. I think there's a big surge, moving the other direction. Thank goodness, from the WHI. 40,000 research articles, and when we looked in August. So times are changing. And there's just numerous worldwide studies involving bioidentical, and the evidence supports that bioidentical can be a safe and effective therapy. I'm always super cautious when I come to using those terms. I would never tell my patients, the bioidentical is safer than the commercial. I would never use those terms because hormones are hormones. We have to go in wide-eyed. We have to make sure we're draining our bathtub. But it can be very, when we replace what the body was doing before in similar proportions and we're monitoring, to me, that's the safest way to go about it. But we have to eyes wide open. So why do we want to do all of this? Obviously, relief of symptoms. And we're going to talk about these other areas of health that hormones play a huge role in. I had a physician tell me that they were taught in medical school that if someone presented with more than 3 or 4 symptoms, that they were a hypochondriac. My ladies have 20 on a good day, and so we really need to, make sure that we're helping them with these things. I did a lunch one time. I was asked to do a lunch at a psychiatrist's office, and going into it, I'm like, compounding. I guess we can talk about a topical Strattera. I was like, what am I going to talk to the psychiatrist about? And I get there and he's like, I want to talk to you about hormones. And I was like, oh my gosh, I love you. Are you kidding me? And he's like, yeah, I have all these patients that come to me and I need to help them with their hormones. And it was just I'm like, wow, then we need more of you, because a lot of ladies are sent to the psychiatrist. And so he was very progressive that he was on top of it. But you can see all of these things and quality of life and how these ladies feel. We need to address all of their symptoms. Because we're living for a very long time, and we're living for a very long time without hormones, unless we're replacing. And so again, it's not the quantity of life, it's the quality. And we want to be able to interact with our family and be active and do all those fun things as we move down the continuum. But brain health, that is one of my big areas of focus. Like when I, was going through perimenopause, I'm like, oh my gosh, I need to make sure I maintain my brain. Like I talk for a living, I educate for a living, and I want to make sure that I can, the synapsing like I'm supposed to. But because we see cognitive decline, it corresponds with that hormone transition. And I've even seen changes in people's personalities. Like you have someone that's super quick-witted, and all of a sudden they like become a little more introverted. It's because they don't think they can find the right words, or they're afraid they're going to say something wrong, and it completely changes who they are. And so it's so important. It's so important to maintain all of their hormone levels. And what estrogen does for females, testosterone does for males. And so we want to make sure that we're looking at both of those patients. This was some studies looking at just increase in cognitive testing, enhancing verbal working memory. Again, being able to recall those words. Benefits on neurodegenerative diseases such as Alzheimer's and Parkinson's. And so again, we want to replace that estrogen, as soon as we're losing it, because those receptors, we want to make sure that they don't downregulate. Our body's pretty smart. It's like the receptor's like, hey, I don't see any estrogen. I guess I'm not needed anymore. And then it kind of turns off. So we want to make sure that estrogen is there bombarding that brain, and there's a lot of receptors in the brain. Progesterone, like Melinda said, it is not just for the uterus. It is such narrow thinking, and that's one thing that does drive me crazy. Is there's receptors in the intestines, in the thyroid, in the breast, the brain. Progesterone can be neuroprotective for the brain, anti-inflammatory, anti-apoptotic, enhances working memory. They've actually used injectable progesterone for traumatic brain injury in the hospital because it is neuroprotective. So think beyond the uterus. We need to make sure that we're giving progesterone regardless. Testosterone in the brain, also very, very important, enhances plasticity. In men, low testosterone levels has been associated with Alzheimer's, and it has to do with that amyloid plaque deposition, which I have a little dispute on whether it's amyloid plaque or phosphorylated tau protein. I have some thoughts on that, but testosterone can be very, very beneficial. Higher testosterone seems to be protective in both sexes for the incidence and development of Alzheimer's. And then there's a higher incidence of Alzheimer's in women. The thought is that we just automatically have lower testosterone than men. And so making sure that testosterone is optimized in both patients, male and female, can help with their cognition. Okay, heart health. Heart disease is the leading cause of death in the US. Women come in and they're like, oh my gosh, I don't know that I want to do estrogen because I don't want to get breast cancer. Well, you're more likely to die of a heart attack than you are to get breast cancer, much less die from it. It's almost like the thing, like if someone tries to take you, you fight to not be taken. If someone's trying to abduct you, because if you run, there's chances are they're not, if they have the gun, they're not going to shoot you. And the chances are that if they shoot you, they're not going to hit you. Same thing with this. It's like, what are the chances we actually get this breast cancer and die from it? Not as great as what it is if we don't take care of our heart health. And estradiol has cardioprotective effects. It actually is anti-inflammatory, and like Melinda was saying, it just helps with just that vessel and making sure things move like they're supposed to. And so there's a significant reduction in cardiovascular events and mortality. And you think about like women do better with heart disease until menopause, right? And so, and that's why they tried to do the WHI study, but they went off the rails and went the wrong direction. Testosterone in the heart, that is also very, very important. And especially for men, like I said, what estrogen does for females, testosterone does for men. And so testosterone has been shown to improve cardiovascular risk, help with that fat mass, lean body mass, and then improve glycemic control as well. Bone health. Bone health is so important. 80% of Americans have osteoporosis, or women have osteoporosis, and 1 in 2 women over the age of 50 will break a bone. Like I said, that hip fracture risk is a real problem, and we don't want to, we want to make sure our bones are protected. And I thought this was interesting that the risk of breaking a hip is equal to the combined risk of breast, uterine, and ovarian cancer. So breaking a bone is a very serious concern. And estrogen can prevent bone loss. It prevents osteoporosis, reduces fractures, and just helps with that rapidly decreasing. So now they're saying, but they said before, 5 years of hormones so to protect your bones, and then that's all you need. And now they're saying if you have a higher amount of estrogen, then when you stop the hormones, then you have this more rapid loss of bone. And they're saying, well, if you do a lower estrogen, then when you stop it, you don't have the same rapid. You're still going to lose bone when you stop estrogen. So I don't quite understand the thinking, but we want to make sure that we, in my opinion, I think we continue estrogen to help all of our systems besides just our bones. Testosterone is also important. Again, it's almost like a concert. All these hormones work together, and it can promote bone formation, suppress bone resorption. And the thoughts, though, are like, okay, is it the testosterone, or is it, we had that one little hydroxyl group was the only difference between estradiol and testosterone? Is it because it's converting to estrogen? That's a question makes you go, but it definitely is important for all of it. And it's important for your lean muscle mass. The more muscle that you're carrying around, the stronger your bones are going to be because you're carrying around more weight. Vaginal health. This has become a very passionate topic of mine. NCPA is our community pharmacy group. I'm like, I'll do a little hotspot on vaginal health. I didn't have as many people show up. I was like, I guess people aren't as excited about vaginal health as I am. The little guy went to introduce my talk, and he's like, you need to introduce it. And I was like, okay. And he's like, I didn't want to say your title. I'm like, it's 2025, man. Come on, you can't say vaginal or vagina. And he was like, I think you need to say it. So anyway, I think this doesn't need to be a taboo subject. Women, when we go in for our exams, they cover everything up and everything's like super, hush hush about what's going on down there. If you guys are doing exams, bring a mirror, show your ladies what's going on down there. Let's make this like a normal thing. It's supposed to be part of it is, it's part of our body. Melinda talked about the microbiome and the estrobilome. There's a microbiome in our vaginal tissue, and it always cracks me up because our body we're like walking microbes is really what we are. And we talk about everything has to be sterile. Well, they've actually found bacteria in the solution in the follicle of the ovary. There was bacteria there. And so it's like we were just literally walking microbes, and making sure that there's a synergy between what's going on with our microbes and our body is key. And there's definitely the vaginal microbiome plays a huge role. And we see these changes with menopause mainly because of just the change in the hormone levels, and it changes the pH, and then that affects the bugs that are there. And it's supposed to be an acidic environment, and the bugs that are supposed to grow and flourish in that environment. And then when that changes, they don't, and then things that aren't supposed to grow do. So that's when we start having some of these other issues. But we see this decrease in lactic acid when estrogen levels fall. I thought this is interesting, just looking at the difference in the vaginal epithelium and the microbes and in the different stages. And you can see as we move into postmenopausal, and is it different whether we're symptomatic or asymptomatic? So when we're on HRT therapy, we can see that things are different, more flourishing microbiome, a little thicker epithelium. Obviously not the same as premenopausal, but definitely better than the postmenopausal not on hormones. And this is why this has become such a passion of mine, is just the recurrent UTIs. So we think, vaginal health, we just think about sex, right? Like, we need to make sure we maintain good tissue so that sex is not painful. It's way more than that. This recurrent UTI, and again, UTI, most of us in the room, we get a UTI, we're like, something's wrong down there, like I need to go take care of it. As we get older, we lose some of those sensations, and a UTI can make a patient delirious, and then they're put on a psych hold. It can put them in the hospital. My grandmother was hospitalized multiple times for a UTI, and then she would have to go to rehab because she couldn't walk after she was in the hospital for a few days. So, I mean, it's a much bigger topic, I think, than we give it credit for. And so most postmenopausal women will have these recurrent UTIs, and it really is lack of estrogen, and that affects the lactobacillus as well. And so estrogen-treated patients had a lower incidence of UTI, and were taking fewer antibiotics than with the treatment. So giving this low dose estriol. Now, most of my patients were on a 0.5 milligrams of estriol. We'll talk about dosing in another session, but I thought this was very interesting because I always thought I was being so conservative with my 0.5. Well, this is 0.05 milligrams daily that they did in these patients. So like a very, very low dose estriol. And they saw that it also not only helped with the vaginal tissue, but it also prevented infections. So again, just getting that pH right, getting those hormones right, getting that tissue right, can be huge of helping these patients. So here's one formula of estriol 0.1% and Elage, which is one of our anhydrous vaginal bases. But I thought this was interesting. Rachel Rubin was one of the authors of this, and I heard her on the Peter Attia show and or podcast. I was screaming at my radio a little bit because she didn't have some things right, but she's very passionate about vaginal health, and they did this study just showing how much money we could save healthcare dollar-wise, and which is great. But I also think about all of those women. I think about all of those women and preventing them from, the hospitalizations, preventing them, like improving their quality of life, all the things that we can do if we just replace estrogen for these ladies. So I feel like every woman needs hormone replacement, and as long as they qualify for it. But vaginal estrogen, we need to really making sure that we're treating the vaginal tissue in these ladies, because long term it makes a huge, huge difference. Okay, so we want to feel great on the inside, right? We want everything good on the inside. Well, we kind of want things to look good on the outside as well, right? And like my patient that had stopped her hormones, she felt like a raisin. She was drying up. That probably really was happening, because we see a decrease in collagen 1 and 3, skin elasticity changes. I mean, you probably have seen your patients, share this with you, that they just felt like they were aging just on the outside. And so hormones in the skin play a huge role. Estrogen can increase dermal thickness, increase collagen, elastin, improve moisture, fewer wrinkles. I mean, women been using Premarin vaginal cream around their eyes for years. That's been a very common thing, that a little hack women have used. Progesterone has also been shown to decrease wrinkle counts, reduce wrinkle depth. DHEA can increase sebum, improve skin brightness. I started using DHEA on the back of my hands because I'm like, my hands look a little papery. And so, because I had gone to a conference one time, and one of the presenters, you could just see like everything was beautiful, and then she kept talking, and I was like, oh my gosh, her hands are showing how old she is. So anyway, I'm very, very cognizant of that. But DHEA can play a huge role in helping with the skin. So we can do these hormones topically as well, in some cosmetic formulas that can really benefit your patients. I like to do an estriol topically, because it's not going to, we'll talk about this a little bit, but it's not going to convert back to estradiol, so it's an end product. So, and Rx3 can make some great cosmetic formulas for you guys with the hormones in them. Okay, so to go over some patient cases, KW is a 53-year-old female, 5'2", 138. And, she's not a hypochondriac. She's got more than three or four symptoms. But I always like to play this little game. I don't know if you guys do this, but I play this little game of looking at their symptoms, and I try to guess what their labs are. I'm like, oh, I bet her labs are this. I'm not always right, and sometimes I'm surprised. But that's why we have both, right? That's why we put it all together. But you can see all of the symptoms that she's having here. Headaches, that's always kind of a big red flag for me. Because especially if they're menstrual migraines, there are some ladies that will tell you, look at a calendar and go, oh, I won't be able to do anything that day because I'm going to have a migraine. Like, they already know that they're going to have a migraine because of their cycle. And so it's more of, we have to be extremely cautious with placing estrogen in those ladies, because it's the change in estrogen that will trigger that migraine. And so instead of completely filling the bucket right away, we have to kind of drip it in. We have to be really, really gradual with bringing that in. So the headaches is always kind of like a little radar goes up. Difficulty sleeping, if we can just improve her sleep, like Melinda said, that can fix a whole lot of things, if we just help them with their sleep. Let's see, achy joints, no sex drive, but then she has increased facial hair. So I'm like, is it because her estrogens dropped below her testosterone? And that was a great graph that Melinda showed us, and I always think of it as balance. I'm old enough that I've played on a teeter-totter on the playground, and so I think of a teeter-totter as far as balance. So it's not that the testosterone is super, super high, but in relation to the estrogen, we'll start having some of those androgenic side effects. Okay, so just looking at social history, massage therapist. Hopefully, some of her colleagues are also massaging her, so she can help with her stress level. And diet, exercise, always take this with a little grain of salt. Nobody wants a bad report card, so they might not be 100% honest when they are describing these things. So usually I multiply that by a factor of 2 or so of, maybe a couple times per week, a couple coffees per day. And then the bowel movements. Okay, she probably knows the right answer, so like your healthcare providers are probably like the worst patients, right? Because they know what to tell you. So really digging into that when you talk with the patient, but family history is unremarkable. So menstrual cycle, she had her first period at 11, heavy clots, that's pointing to progesterone for me, PMS, mood swings, cramps. Last menstrual period was 2020. The pregnancies, I also want to know, like, how did you feel when you were pregnant? There were some ladies that were like, oh my gosh, it was the best, it was the greatest, I loved it. And there's like, it was terrible, I hated it the whole time. And then others like, I was pregnant. So you have those two swings. Someone that felt fabulous is going to feel really good on progesterone. Someone that had a really hard time is going to have a hard time with progesterone. Everyone else is kind of in the middle. But looking to see if they had interrupted pregnancies kind of always clues me in as to whether maybe they had trouble with progesterone to begin with. Some young ladies just have a hard time like kicking off that whole cycle until they have their first pregnancy. But this next one is like the vein of my existence. I understand the endometrial ablation, but man, is it hard to figure out what to do with these patients because you just don't have the outward signs. They have all their parts, but we just don't know anything because we've ablated their endometrium. So anytime I see that, I'm always like, oh, that makes it another piece of the puzzle, makes it challenging. Mammogram was normal. Also like to look at like what OTC meds that they're on, what vitamins that they're taking, because that always kind of clues me into where are they really seeking help? Like what problems are they having that led them to that? So the L-theanine, she probably is feeling some stress, right? So she's taking theanine to kind of calm things down. Magnesium, she probably, as a massage therapist, knows that that's extremely helpful. The other supplements are great. Relpax, so she is a migraine sufferer, which she reported having, several headaches per month. So again, this is a patient I'm going to be extremely careful with. Birth control gave her headaches. Again, she's going to be extremely sensitive to the estrogen. So her testosterone wasn't totally bottomed out, and it's not super high either. It's just disproportionate to the estrogen. So she's really not making any estrogen, and she's making a little bit of testosterone. FSH is screaming at the ovaries to make more estrogen, so she's definitely menopausal. Vitamin D, I don't consider that optimal. I like it 60 to 80. It's kind of my go-to. And so definitely going to want her to boost up her vitamin D to try to achieve that goal. I mean, especially if she's, has some inflammation issues going on, the vitamin D can help with the inflammation. And we have all of our ideas, right? We look at their labs, we look at their symptoms, and we're like, aha, I'm the problem solver. This is what we're going to do. Well, we kind of need to include them on that. Like, what are their goals? Because we want to make sure that we get them in, we get them involved, and start to address some of their goals. Now, sometimes we have to explain that I understand this is your goal, but we need to start here. We need to work through this progressively, but we need to understand what their goals are. And I agree, we need to get her sleeping because I think that's going to fix a lot of things. And then when did you feel your best? Early 30s, I was in shape, took better care of myself, and had a good job. And so, to me, these is always like, oh, we just need to get you there. Like, we want to help you get you there. And so we're gonna start with that. I feel like every woman going through menopausal transition, perimenopause, I think we all need help with our adrenals. Our adrenal glands were meant to pick up when our ovaries stopped, but the life that we're living, 365, 24/7, like we're just go, 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 that our adrenals are like, I'm tired before we're even really needed. So I think we need to support the adrenals. I like the adaptogens that Melinda mentioned earlier. I like to do a family of adaptogens so that we're not putting all of our eggs in one basket. So we're kind of taking on all of the different ones. Probiotic, again, making sure that our gut is healthy, and some of that's going to go vaginally as well. Increase her vitamin D because I don't think her levels were optimal. And then I'm just going to do a baby dose, like a very, very baby dose. And then we can slowly increase that up. If we just drip it in for her, we can get her up where she needs to be without triggering those headaches for her. Testosterone 0.5, that's kind of where I typically will start as well. And that also could be done in a rapid dissolve tablet. We'll talk about dosage forms later. But I found that to be very, very successful with my ladies, is and that's how I do mine, is a sublingual testosterone. Testosterone, I think, is a little harder to get across the skin. Estrogen and progesterone do very, very well, but testosterone can be a little more difficult for females. progesterone, and then again, we need to make sure we're helping with her vaginal health. So a 0.5 estriol is kind of my go-to. I say nightly for 2 weeks, and then 2 to 3 times per week after that. If after 2 weeks they're like, yeah, I mean things are okay, but they're not great, I'm okay if we do that longer. Like, if the tissue is really repleted, it may take a little bit more time to get that moisture back. I've had some ladies tell me that they were so dry that they felt their insides when they bent over, like it hurt to sit down. So it's more than just sexual function. So we need to do that a little longer. I'm okay with that. Okay, so I didn't leave the gentleman out. So here's a 52-year-old male, 5'10", 284. His symptoms, moderate to severe, increase in waist size, difficulty losing weight, mental sharpness, decreased sex drive, decreased early morning erection. Whenever we're having erectile dysfunction, one of the first things I think of is cardiovascular disease. And so, that's sorry, you guys in the room. That's the one thing that will get a guy to come to the doctor, right? That's not working. And so if they're having that, we need to make sure we're evaluating them cardiovascular as well. And then less enjoyment in hobbies. That tells me that his testosterone probably is low as well. Just that lack of zest for life. When you have that anhedonia, that's just kind of the flat effect. Their hormones are definitely off. He does have high blood pressure, so let's make sure that it's controlled. He is on vitamin D 5,000, magnesium, zinc. Zinc is real important for gentlemen. So I always like to give zinc to, I think everyone needs a little bit of zinc, but guys especially need zinc. And then he's on lisinopril and hydrochlorothiazide. So glucose, 115, yikes. Hemoglobin A1C, not in the pre-diabetic phase, but definitely heading that direction. Like we need to course correct. Like we need to really help him with his glycemic control. And a lot of times with all patients, but men especially, if we can help them metabolically, that fixes a lot of things downstream from there. His TSH is borderline. I mean, 2 is the upper end of where I like to see it. But all we did was a TSH and a T4. So you would look at this and go, check, we're good, no problems. I would want to see more information with his thyroid. TPO antibodies, it's not blasting, but it's there. So kind of what's going on with his gut and his immune system. B12 is just barely above where it needs to be to get to the brain. It needs to be 600 for it to get to the brain. And so, that might be something that we look at, and then his folate is good. But his testosterone, barely in range. And I guess it qualifies, the normal things is it has to be less than 300 before you can treat whatever. So he definitely could use some testosterone. PSA is good. Estradiol is good. I mean, it's important for men to have estradiol as well. It's important for their bones as well. But we want to make sure that, like I said earlier, that we're not converting the testosterone to estrogen. So that doesn't seem to be a problem for this gentleman. His his vitamin D could be a smidgen better. So I would probably maybe bump his dose a couple times per week. Maybe he takes 10,000 a couple times per week and 5,000 the rest of the time, just to try to get him into that 60 to 80. They say for every 10 points, you want another 1,000 units. So if we wanted him, say 20 points, he would need 2,000 more units per day. Sometimes that's difficult with how the supplements are out there, but since it's fat soluble and it's going to stay around longer, you can just maybe a couple days per week have him double up to make sure he's getting enough for a week. I don't like the weekly dosing of vitamin D, just because you're putting all your eggs in one basket for that to be absorbed. So I'd rather see it split out, throughout the week. Now, if you don't have a patient that's very compliant, then obviously better just to get it in and run that risk. But I do like to do it daily. He wants to lose weight, increase energy, increase sex drive. He's 52 and feels like he's 60s or in his 60s. So we definitely want to help him with that. Fish oil, especially the cardiovascular things he has going on, the metabolic things he has going on, help support his gut. Adrenal support, ashwagandha, we don't know what his T3 is because they didn't test it, but ashwagandha is really great at helping convert T4 to T3. So again, I would want a more in-depth thyroid panel when we go to retest again. Multivitamin, he wasn't taking a multivitamin. And then berberine. Berberine is great for helping with insulin resistance. So it can really help with that glycemic control. And then obviously he needs some testosterone. So I would do 50 milligrams topically. We can always adjust from there depending on how he does. So key takeaways, hormone balance takes time. These patients didn't get where they are overnight. They're not going to get them back overnight. I wish I had a magic wand to make everything perfect, but it takes time. We have to find the right dose for each patient and start low, especially estrogen for females. Like, estrogen's a drug. I mean, you think about, like, after our cycle, like, I'm going to take on the world. We're great. And if that's how we're feeling all the time, like, yeah, don't take my estrogen away. If you've ever had those ladies that were on like super high doses of estrogen, like, it's very scary. They don't want to come down. So make sure we start low and slowly increase them. The compounding ingredients makes a huge difference. The base that you use makes a huge difference. We'll talk a little bit about that later. But choosing the right pharmacy, obviously you guys are in the right spot. You're here with Rx3, one that does quality ingredients, detailed procedures, quality control processes. That's so important. If for some reason you had a patient that was getting something filled somewhere else, you might see very, very different results because of how the pharmacy is compounding those products for them. PCCA, we go above and beyond. So we supply all of the active ingredients, all the bases, obviously the clinical support from my team, but we really want to make sure that the ingredients that Rx3 has are the best quality. And so we assess those manufacturers, making sure that not only are they an FDA registered facility, but they actually have been inspected by the FDA. That's not a requirement. It's not a requirement for them to be inspected. So we make sure all of our manufacturers meet those qualifications. We test their products when they come in. We make sure that that white powder is really what it's supposed to be and there's no other things in it. And then our formulation team will actually test the formulation. So Rx3 doesn't have to go through the trauma of a product failure or formula failure. We do that on hand. And then we reassess those manufacturers. We've been in business for 44 years. But just because we worked with someone for 40 years doesn't mean they get a pass. We check and double check every time they come in just to make sure, just because it's too important. Because quality matters, the accuracy, the precision, reproducibility. I mean, you want to make sure that your patients are getting the same results from month to month. And those clinical outcomes for your patients really makes a difference. I pulled up a C of A for estradiol here, and I kind of highlighted out the particle size. So the specs are the first little box, D90 less than 20. So that means that 90% needed to be less than 20 microns to meet the specifications. Oh, okay. Well, okay. Thank you. Yes. Yeah, I know. And then, but the results were 5 micrograms. So, so it's just the smaller the particle size, the better the absorption is. So I think this is very valuable. And with that, I'll bring up Miss Melinda and we'll answer any of your questions. I know you had a question earlier.
Yeah, I had a question about a couple of questions actually. So with women, I know we talk about they have family history of breast cancer. What if they've had breast cancer?
It depends on what kind. It's very, very important to know what type. If it's hormone positive, of course, that's a different conversation. If it's hormone negative, that's going to be an informed consent, real deep, in-depth conversation. And if you're my doctor, if you're my prescriber, I want you to give me the choice. I want you to give me agency. Of course, within your comfortableness, is that a word? Your level of comfort. But yeah, that does make it a whole different conversation.
And it's tricky because of the data. Like, that's where I land. Like, I'm super conservative. And so my look at the data is if they're 8 to 10 years post-cancer free, then I feel like their risk is similar to mine. But again, I do think the patient needs to have the choice. One of our doctors that speaks for us, she brings in the patient's family with the patient and has the patient sign the consent that she realizes that she's, there's not data to support what she's doing, but the family witnesses her signing that document, because if the patient dies, she's not suing, it's the family. And so I thought that was very, very powerful because again, it's putting that back in the patient's hands. Like, is this something she wants to do? I always like to be as conservative as possible. If there's things that we can do to help with vaginal health that's non-hormonal, I'm even a little concerned. I know oncologists are like, it's fine to give estrogen vaginally for breast cancer patients. I'm a little concerned because they only tested serum. And so there were some of those studies I read that they said that, oh yeah, it only stays vaginal, but it helped with the vasomotor symptoms. I'm like, well, it didn't stay down there, then it helped with the hot flashes. So I'm even cautious with that. I would rather I'd rather do non-hormonal, and then if I have to dip my toe in, I'm going to do a little estriol and maybe like that 0.005%, like very, very tiny. But I mean, it does need to be a patient choice, but that's a little, I hate to deny a woman hormones, but at the same time, I'm like, I don't have the data to say, yes, for sure, you can do this. Yes, ma'am.
So I'm a functional medicine provider. I have a young lady who's low progesterone. She had many miscarriages in the past. Currently treating her for like agoraphobia. We've done oats testing, and she's got lots of micronutrient deficiencies. So I'm working on that. But I wondered, like, when would I introduce progesterone, or would I? You know, right now I'm just doing all the supports and trying to clear the pathways.
How old is she?
22.
Oh,
She's right in that little sweet spot of when do you start? I would say a lot of that would go on symptoms. Is she having trouble sleeping?
Some.
Yeah.
is she still wanting to conceive?
No.
Okay. 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 Yeah.
That's another good point. When you start supporting HRT during perimenopause, you need to have that contraceptive conversation because it can increase your fertility. So there's.
And would you do progesterone alone ever?
Yes.
If she's still making estrogen, yeah. So that's why.
Do a Dutch on her. That's the next plan.
Yeah. Yeah. Yeah.
Yeah. A lot of times we just start in early perimenopause with like luteal phase progesterone, day 11 through 25 or 14 through 25, whatever you can kind of play with that. But that can be real effective in early perimenopause because the first hormone to decline is progesterone.
For sure.
So,
And that a lot of times can help kind of balance that chaos, like you talked about. Just the progesterone can kind of help with that. Is when to start that estrogen, that is tricky because, you know, I use the ketchup bottle analogy, and I like to say that the ovaries sputter, you know, so nothing, everything, you know, and so it's like when to introduce that you don't all of a sudden have estrogen on board when it sputters, that then we're going to have excess bleeding and issues. So that's a tricky time. I think perimenopause is the most difficult time for women.
Perimenopause is like cat and mouse because it's a moving target.
Right.
You're literally on a roller coaster, and you can best guess testing. You know, we like to measure so we can manage what we measure. But when you're talking about being on a roller coaster, it's hard to tell if you can visualize the menstrual cycle map, what day during the month are you actually testing? And so is your level supposed to be low that day?
Or on day 19.
Day 19
Yeah.
is
Yeah.
great.
Right.
But then what if she's got a 25-day cycle, or what if this month her cycle's 37 days?
Right.
You know, when I test my patients, I normally don't give them the results until they've had their next period so that I can go back in and see exactly like more of what day that result was on. If that makes sense.
For Sara.
Or saliva too. Yeah. Yeah. Awesome. Yes.
A lot of what you've talked about is like perimenopausal, and the data that you presented also was that, you know, the later you are starting hormone replacement, you know, the results are not quite as good. Is there a point that it's too late, that you're not going to get any benefit from it?
That's an excellent question.
That's a big controversial
It
question
is,
right
yeah.
now.
Yeah.
Yeah, there's a lot of controversy about that because there's the Chronos study showed that the earlier you start, the better. So there are some providers at the camp, if you're more than 10 years past menopause, sorry, you're out of luck. Then there are providers that will do a very careful coronary calcium score or get assess your cardiovascular disease risk, and then make an informed decision that way. But I think it's as many providers saying yes you can as there are saying no you can't. I think.
And I think that there's more benefit if you start in that window. If that, you know, some say 7 years, some say 10-year window. You know, or starting before, but there's not a lot of data showing that there's no benefit if you start later. You know, so I mean, and I saw some studies on bone loss, and it was saying that you're not going to say you've lost whatever percentage and now we start hormones, you know, 15 years later. We're not going to gain back, but we're going to slow down that progression moving forward. So you're still making some impact, but definitely checking out cardiovascular disease, making sure we're using, I would be extremely cautious. I would do, and we'll talk about ratios of the different estrogens later, but probably lean heavier on the estriol, which is the weaker of the estrogens. Making sure we're doing it topically, balancing with progesterone, like looking at really everything holistic, making sure her bathtub is draining, all of those things. Yeah. Yes, sir.
Going back to your breast cancer, if it's a triple positive and she's on estrogen blockers, would you prevent using testosterone?
That's an extra. Yeah, that's an excellent question.
I think I would have to also play into that conversation. How many years has it been since the diagnosis?
On estrogen blockers right now.
Yeah. It's tough because testosterone alone for a female without estrogen increases cardiovascular risk. And so that's why we wouldn't give testosterone to a woman that didn't have estrogen. And so, and then she's not going to convert it, but maybe a very baby dose would be, worth looking at. But it would, I don't know. Well, if she's on a blocker, it's not going to convert. So just throwing that balance too far off with not having enough estrogen on board to having too much testosterone and what that's going to do for cardiovascular risk. So that's a tough one. Like I said, I hate denying hormones to a woman, but also want to err on the side of caution too. So, yeah. Yes, sir.
In some of my office visits, I have been presented the issue where you have a premenopausal, gestational birth age patient that is on birth control pills, and the notion of giving them testosterone to counteract some of the anti-androgenic issues with the oral.
Yeah, I've definitely seen that. A lot of ladies on oral contraceptives have low testosterone. And so, again, checking levels to make sure where they are. And, most of my providers that I worked with were fine to give a low dose testosterone to those women just to kind of get them back into a good range. Yep. All right. Any other questions? Oh, yes, ma'am.
Really off the wall question, only because I've been approached a couple times. What are your takes on the pellet therapy? I'm gonna refer to you on this one.
Yeah.
I have a negative personal story with pellets, so I kind of try and refrain from.
Yeah.
I will share it, but go ahead.
Yeah. So I know my view on it is skewed because I don't see the patients that do well, right? So the patients that do well, they continue doing what they're doing, and I never hear about it. So I know there's a population of patients that do well. I see the horror stories. I see the levels that are, crazy high for 6, 9, 12 months after the last insertion. I did a presentation on pellets, and I was like, from Promises to Pitfalls was the name of the title, because it sounds great. And like Dr. Rebecca Glazer that I mentioned earlier, she was a big pellet, fan. And it's like, oh, if it can just slowly release the hormones like my ovaries, that sounds perfect. And I think it can be done right. I just don't think it is done right most of the time. I think it's once those levels, so the levels come up, so the estrogen comes up, say it comes up to 100 serum-wise. When the levels drop back down to like 60, the lady's symptomatic. And it might be at 8 weeks, 10 weeks. I'm like, oh, let's give you more pellets. And so they do another insertion, and then another insertion, and another. And so those levels she's symptomatic because of the change in hormones, not because she needs more. And so we see levels go crazy. If a patient comes to a pharmacy now and I'm talking to them, I'm like, just because they're due for the insertion doesn't mean that you go ahead and start the topical. We need to watch those levels come back down to a normal range before we then initiate more hormones on board with that. So I'm not a huge fan. And I think the first insertion is, I've never done an illicit drug, but I think it would be like an illicit drug where like, the best high ever, because of the release of it, everything is perfect, but then you get scar tissue. And so the next insertion is not the same, and it's not the same. And then you just kind of build more and more. I don't know. I think if it's super low doses and it's done every 6 months, that probably is fine, but that's not how it's done. So
I am more of a case study of the wrong ways to do things in my personal journey. I had an endometrial ablation in 2016. because I went in when I was having a cycle every 2 weeks. Doctor's like, we don't care why it's happening. I'm going, why is it happening? We don't care why it's happening. Let's just burn it and get you out of here. Get you out of my office. Didn't know any better at the time, so I had an endometrial ablation. 6 years later, in the throes of perimenopause, I go into my doctor's office, and one random Tuesday, they're just like 3 o'clock in the afternoon. Let's test your serum and see how your hormones are. Came back 0. Didn't take any consideration of when I am in my cycle because I can't tell because I've had the ablation. Didn't take any consideration about timing of anything. And they said, you're 42 years old and you have no hormones. You're in menopause. You're in menopause at 42 years old without timing my serum levels on any certain day or whatever. And so I'm sitting there in the office crying like, I'm 42 and I'm in menopause. What? I mean, like, what have you just told me? And they're just like, you're in menopause. Have a nice day. And so they were like, well, I said, wait. What are we going to do about this? Well, we can support you with some cream, or we can do a pellet. I mean, just put it in and forget it, right? So I was like, yeah, sure, sign me up. Didn't do like the right testing, didn't even know where we were starting, and I got testosterone pellets and estrogen pellets all at the same time. Had never been on a cream, had never been on an RDT, had never been on anything. My first exposure to hormones, and it was a train wreck because the dose was too high. I had not been on any hormones at all. And the pictures of my inflammation that I showed when my resting heart rate was 116 and my rash and my fingers couldn't fit on my fingers. My rings couldn't fit on my fingers. That was 6 weeks post pellets. Because now that I know what I know and I've done my own genetic testing, I am a poor metabolizer of testosterone. My testosterone went to 200 and didn't come back under 100 for 12 months. So I have a personal train wreck story with testosterone. I gained 35 pounds in 6 weeks. I was smelling perfume 24/7. Phantosmia is what it's called. I didn't know what it was called, but I had to investigate it. So I see the reasoning for pellets. I see why people think that they're great. I would say never start someone on a pellet. Always make sure that they can, what their body's going to do with the hormones that you give it. Like, you got to test the metabolism and how their genetics are, and so many other things need to go into the conversation of pellet therapy that I think is getting overlooked a lot of times. So
I just think it's, from what I'm looking at, it's very expensive.
it is.
And as a primary care provider, it's like you want to help them, but financially it's a big cost.
Mm-hmm.
And also, once you get the pellet in, I
It's there.
can't take it back.
That's right.
So it's like if you have I have a lady that had a pellet insertion somewhere, I'm not sure where, but she came into my office for primary care. Her blood pressure's 200.
Mm-hmm.
She's never had a blood pressure problem. I don't even know what your levels are right now. So I just don't feel it's very safe,
Mm-hmm.
and it's also very it's not cost effective from a patient.
Yeah. You're also inserting a foreign matter into the body. So what's the inflammation process going to look like around that? I've seen some things like some extrusion inflammation and infections that have occurred. I'm not a fan, but I do know it has its place, and I know that it's not something that's going to go away. So we do need to learn how to deal with it.
Yeah, and that's just the hard part. Like, I feel like I have too many control issues to do a pellet. Like, I like to be able to control what I'm doing, but versus, like you said, once it's in, it's in.
Oh, let me finish my story. I didn't finish my story. When I did the pellets, it kind of woke up that endometrial lining that didn't get burned during the ablation, and it started bleeding. And 9 months later, I ended up with a 13-centimeter hematometra that I had to have a hysterectomy to remove. So, that kind of gives a little bit more fuel to my fire.
Right.
Yeah. So.
Well, great.
Well, now you don't need progesterone.
I don't need it, but
She's smart enough to know she needs it. Yeah. All right. Any other questions?
Is that for a break?
Yep.
Yeah.
Lunch will be here at 11. Oh, it's here. Okay. So food tables are next door. Yes, you can go ahead and have lunch. Thank you guys so much. Really appreciate it.
Yeah.
We'll meet back in here at what time?
I guess I went fast.
1 o'clock.
Yeah, they're gonna like to demonstrate devices and stuff. Are they doing that later?
I think he wanted to do that later. Sorry, I guess I'm a little fast. Oh, thanks.
Great job,
All
guys.
right, thank you.
Why can't I find the power?